Bonjour and good afternoon, ladies and gentlemen, and welcome to another session of the CSPC virtual series. And today we are pleased to have with us Dr. Vivek Goel, professor at Dalla, Lama School of Public Health at the University of Toronto. And welcome to our session, Dr. Goel.
Pleasure to be here, Mardad.
Hey, I just want to start with a brief introduction about Vivek, and I tried so much to cut his CV and his bio short. I must say, it was very hard, but let me just read through a few things that I thought it's important to be mentioned. Professor Goel is a distinguished scholar with an extensive background in teaching, research, and university administration. He obtained his medical degree from McGill University and completed postgraduate medical training in community medicine at the University of Toronto. He also has a Master of Science in Biostatistics from Harvard University School of Public Health. His research has focused on health services evaluation and the promotion of the use of research evidence in health decision-making, very relevant to today's world. He served as the university vice president and provost from 2004 to 2008, and he was a founding scientist at the Institute for Clinical Evaluative Sciences, where he continues as an adjunct senior scientist. He served as founding president and CEO of Public Health Ontario from 2008 and 2014, where he was highly successful in building an academic public health services agency that provided scientific and technical advice to frontline professionals. He returned to the university as Vice President of Research and Innovation and Strategic Initiatives and served on that role from 2015 to 2020, about 2 months ago. And he served on the boards of various institutes, including the Vector Institute and Triumph and the Canadian Institute for Health Information. He is a member of Governing Council for CanCOVID, the National Research Platform for COVID-19 Research, and the Board of Post-Provost. He is also the co-chair of the university's Response and Adaptation Committee, a committee that is formed in response to COVID-19 and lead its recovery and restart activities. He is also on the Committee of Federal COVID-19 Immunity Task Force. So as you can see, he's involved in a lot of work that can be related to today's realities and the pandemic and the issues that we are dealing today. Welcome to our program and our session, Dr. Goel. You have previously participated at the CSPC conferences and strong supporter of CSPC, and thank you for your presence here.
Great to be here.
Okay, so today's format, similar to the previous times, I ask a couple of questions until about 12:15, and then we open the question and answer box in the bottom of the Zoom screen for the participants to ask questions. And I want to thank those participants who took time off their busy schedule and attended our session, and look forward to hearing your questions as well. So, Vivek, you have been among the very few researchers who have done research on evidence and on evidence-based decision-making, and have dealt with policy and advice in various capacities. And when we refer to evidence-based decision-making, you are one of the best to tell us what's the meaning of evidence. So how do you define evidence?
Yeah, so thanks. That's a really important question. And one of the most important things is recognizing that evidence itself as a term means different things to different people. So back in the 90s, we had a national network of centers of excellence called HealNet, the Health Evidence Applications Linkages Network, which brought together researchers from across the country to really, at that time, what was still a relatively novel concept of evidence-based medicine, and expanding that to think about evidence-based policy, evidence-based health services. And I remember one of the projects that we did, and Ross Upshur was a graduate student with me at the time. He's gone on to, he's a whole professor now at the Dalla School of Public Health as well, actually did a summary of all the definitions of evidence out there. And we had literally a monograph of evidence as defined for different disciplines. We came up with a framework for evidence that we called meaning to measurement. And I think the important thing to bear in mind is there's a scientific perspective, and often expressed in what I will frame as traditional evidence-based medicine, which is very quantitative, based on trials and evidence, which is very appropriate for answering questions like, does this drug work for this disease? And to really answer that question well, you need to do a randomized controlled trial with blinding and so on. But there's lots of questions, and there's lots of times when you need evidence that might come from different research approaches. You might need qualitative information. You might need information on surveys about people's intentions to do something. You need the evidence about what are people's values and what are their preferences for certain things. And so we have developed a much broader conceptualization of evidence that captured not only that very reductionist evidence that is appropriate for certain types of questions, but that broader range of evidence that still comes from research, but from different research disciplines, from political science, sociology, psychology, that will also inform decision-making. So when we talk about evidence-based decision-making and evidence-based policy at a government level and sort of we're at the Science Policy Center, we have to be thinking about the fact that those decisions integrate all these different types of evidence together. And then when we get to the kind of situation we're in right now, where that research base is evolving very quickly, we get into a larger set of challenges of how do you integrate information from so many different sources into informed policy in a rapid manner that meets the needs of the population, particularly when that underlying science base can be changing very frequently and sometimes in different directions.
So could you elaborate, you briefly mentioned the evidence-based decision-making pandemic in this situation. Could you elaborate on the challenges in doing a science-based policy during a pandemic as we have experienced so far?
Yeah, so there's a few challenges to doing science-based policy in a pandemic with a new virus, right? So if we think back to late 2019, there was no science in terms of what we have today. We had a knowledge base. We had a knowledge base about SARS-CoV and SARS-1, MERS, some of the other similar viruses. We had knowledge bases about respiratory viruses. We had plans for influenza pandemics largely. So we had things to draw on. And so if we think back to January, February, a lot of the recommendations that were coming out were based on science that was from earlier types of SARS viruses or other viruses or other respiratory infections altogether. And so when we say, what do we know about public health measures and their effectiveness, largely they were based on our experience from the 1918 influenza virus, right? And so that was an experience that over 100 years ago, the world was a very, very different place and a different kind of virus. So at the start of something like this, you're dealing with basing your policy on evidence that you draw from other similar conditions as close as possible. Then the next challenge, and we still remain in this, is we have rapidly evolving knowledge. The early evidence that comes in is from the earliest outbreaks in Wuhan, China, in other places. We have then studies of different types, epidemiological studies, basic science studies starting to get done. I think one of the challenges that the current pandemic we've really seen at the fore is the way in which science moves out into the public domain has really evolved. There's some really good things about that. We have a real strong commitment to open science. Unlike in some previous situations, we didn't have people sequestering the virus and the sequences. It was put out freely right away, which enabled us to develop tests and so on. But the challenge with being very open is we also have a lot of individual studies being released through preprint servers. They're available to the public, to the media right away. We've had some very high-profile retractions, even from peer-reviewed, major peer-reviewed journals. Hydroxychloroquine is an example. You have one study come out, it starts to drive major policy, and then it's retracted and subsequently shown to be dangerous, right? But how has that influenced our public policy in the last few months? And so we can have many examples of where individual research studies, which in the normal course of evolution of science add to a body of knowledge, it gets synthesized, it gets compared, maybe there's contradictory research, but now we have individual research studies getting major headlines, major attention, which often drives decision-making and policy. And the final challenge, I say again, which is I think very unique to the experience we're having with COVID-19, is the volume of science that is now being done is unprecedented. So in Canada alone, the last time I saw it added up, probably in early July, we've had from the federal government alone over $2 billion of investment in COVID-19 research since CIHR ran its first competition in February. So if you think in 6 months, $2 billion is the annual budget of CIHR, right? So let's put that in perspective. In 6 months, we have thrown as much at one virus as we do in all health research every year. If you look at that on the global scale, and again, I don't have the latest stats, I looked at this a few weeks ago, I think we were up to about 400 papers a day.
Wow.
So how do you keep up on top of that, right? So even if you're the Centers for Disease Control, having enough people to keep up on top of everything. And so when we say it's challenging, you have this volume of science coming at you through channels that are not traditional, preprint servers and so on, and you have to keep up on all of that. So I don't envy the task of the people that are in those roles in public health organization and health systems, trying to integrate all of that. And then you've got to take account of where are public values at, what are the other considerations, where are our resources at to deploy for this. And so it's very simple to say we're going to do science-based policy, or you know, when a politician say I'm relying on the science, to me it's actually questionable, because I think it's hard to say you're actually relying on the science, because you got to rely on all of the science, not just a science.
So with that, first of all, I want to ask participants if they have questions, they can start writing it. But let me ask you, referring to your last sentences, last few sentences, how are we doing in coordinating COVID-19 research in Canada, in your opinion?
So I'll say, again, first of all, I think we have to say it is tremendous what we have been able to accomplish in literally 6 months, right? It's 8 months since the virus likely got introduced to man, and really we started in Canada to pay attention to it in terms of a research perspective late January, February. And so where we've got to is unbelievable. And, you know, the CIHR first and second competitions, they turned those around in record time with online peer review. So it wasn't just running the competitions, we're actually inventing new ways of doing things virtually in how we do our research, how we do our research competitions. So I think we have to give credit for what's been done. But, you know, I would say, I think as we reflect back on where we've come, one of the concerns I would say is we've had a lot of competitions. And we've had a lot of funds flow out in discrete pots. Genome Canada, NRC has been doing initiatives. The CIHR, CFI had a special competition. So we have lots of things going out. And if we say, you know, right now, we have some critical questions about the reopening of schools. We have critical questions around borders and testing. And you say, well, who's doing research on this? Well, those aren't necessarily questions people posed back in February or in May when some of the competitions happened. And some of them are not necessarily questions that would go through a CIHR science review process, right? So, you know, what's the prevalence of COVID-19 in returning travelers? It's a very important question from a public health perspective, but from a science perspective may not be top of mind that our researchers want to put their energy into. So where I feel that we do need to really get some better coordination is identifying what are the most important questions from a public health and health system perspective that we need answered. They may not be rocket science. They're certainly not going to win people Nobel Prizes, but they're going to be very important to getting us out of this situation or helping us manage the situation for the months or years that we may be in it. So having some mechanism for coordinating across the funding bodies, coordinating across the research doers, the research institutions, the researchers, across the provinces and territories, because they're also funding research, the private sector, to make sure that there are not gaps in our knowledge base around some of the critical areas. So as an example, you mentioned in the introduction, I'm part of the Immunity Task Force.
Yes.
The Immunity Task Force was announced in the same briefing by the Prime Minister as the funds for the CIHR Round 2, as well as the funds for Genome Canada and some of the other research initiatives. Right? So the Immunity Task Force has a very specific mandate on looking at the seroprevalence through serological surveys of antibodies to COVID-19 in the Canadian population and in specific population groups that we may think should be studied, and as well as doing fundamental research on the nature and duration of immunity in those who have had infection. And those are critical questions we need to have answered alongside of work on vaccines and antivirals and other areas, and this task force is now created in those areas as well. And so the approach that the task force has taken has been to look at who's doing this kind of work, who's been funded or who applied into CIHR. And there we see many people that are already conducting research that are relevant to this. But we're also going through the process of identifying what the gaps are. And then what we're going to do is a more proactive and strategic approach to having expressions of interest or other forms of calls for funding to get those targeted questions that, given the mandate of the task force, are felt to be essential for the country to have answers to. And so I think we need to look at that sort of approach across the entirety of research around COVID-19 so that we have coordination, we have efficiencies. We don't, one of the things, again, with competitive processes as well as different funding agencies, we could have the same study being done many times. Or, and I think this is something that I think from an ethical perspective, I think we really need to be thinking seriously on. In the spring, I think on the Health Canada site, we had over 5 hydroxychloroquine trials registered in Canada. Why are we doing so many trials on something that there's no basis to be doing that? And it's a resource issue, but it's also an ethical issue, right? Because we could have other antivirals for whom now we don't have the people are being enrolled into these trials and they're not available for the other trials. And so the lack of coordination could lead to some very serious consequences if we have those sorts of things continuing.
Okay, thank you for that elaboration. And I have a couple of other questions, but I also want to make sure that we have some questions from the participants. And please feel free to vote up any question that you may like. And there is a question by Brian Bakery. It asking the question that what evidence supported the decision, apparently that decision is reserved, that U of T allows the students to, no, they don't need to wear masks when they return to classes in the fall, asking the question if there has been any evidence led to this decision or reversal of this decision.
So, I think that's a really important overall question, and going back to my role at the university, and what for me, having stepped out of my administrative role to focus on both helping the university in its response as well as helping our community in the research, I wind up being some days on the researcher side and other days, or maybe in the same day, from one meeting to the next, being the person helping to develop policy and integrate evidence coming from different sources, as well as being the person generating the evidence. And so the first thing I'll just say is I don't think it's fair to characterize this as reversals. The research and knowledge base about COVID-19 has evolved since the start. It's not just U of T, our public health authorities right across the globe have changed their position on the appropriate use of masks of different types, cloth masks, medical masks, and N95s throughout this as knowledge has evolved. And so in terms of going from the early positions that masks were not needed was, as I said, was based on knowledge from other infectious diseases, respiratory infections, and the entire public health community, certainly in the United States, Canada, Europe, was in the same position of not recommending the use of masks. Then we evolved to a point where we started to recommend the use of community masks when physical distancing was not possible. And then in July, we went to, certainly in Ontario, but across most parts of Canada, to mandates for masks in indoor spaces. And so the evolution was based on the evolving knowledge base, particularly around pre-symptomatic and perhaps asymptomatic transmission from people who are infected with COVID-19, shedding virus, but not yet showing symptoms. And so that evidence base was suggesting that the use of those masks in the community could reduce the risk of transmission. And I'll also, because I see that Brian has evidence in quotation marks, I will be quite frank and say that the decisions are driven not just by the evolving research base, but the evolving social norms and social attitudes. That is, in my broader conceptualization of evidence, is all of the things that we're integrating. And so as the university makes its decisions, it's looking at what is the city of Toronto, the city of Mississauga, where we have a campus, doing, what is the province doing, what are others doing, and those are all inputs into that type of decision process. And I think that's the same thing that our public health authorities go through on a daily basis.
Excellent, thank you. Before going to the next question, I want to ask my colleagues at the CSPC office, please launch the first question survey asking the sector of the participants, which sector you're coming from. These, your answer help us to better prepare for future sessions, and I appreciate your taking time to respond to that question. The next question, Vivek, for you is from Peter Serlis. He asks, your mention of open science and retractions was very interesting. What do you see as the solution towards balancing the urgency of research and dissemination in an emergency against the thorough and rigorous requirements for peer review and scientific process? An interesting question.
Yeah, it's a interesting and it's a very important question. And so certainly I would not move away from a commitment to open science and rapid publication. I think, and I think in reality, the scientific community understands what a preprint is, and I think approaches preprints and so on with the appropriate degree of caution. So my comment would really be more is, how does public policy get driven in this era? And as I said, social media and other communications technologies have really changed how things are getting driven. And when you have the President of the United States harping on some of these things that are coming out, like the early hydroxychloroquine studies, it does drive policy, right? Mm-hmm. So I don't necessarily see the solution here being something that the scientific community has to change the practice, but I think we do need to do a better job when we communicate. If we're asked by the media to comment on an article that's been released on a preprint server, we have to constantly remind them, this has not been peer reviewed, it could change. But if we start as a community to treat those early releases that haven't gone through peer review as definitive, I think then that starts to have an effect on the other communications and what's happening out there. I also, there's the preprint issue. There's also the sort of the sharing of data, vaccines, on the virus and so on. So, I think it's important that we think about open science broadly and not just open publications.
Thank you. And Vivek, before waiting for other questions, I want to ask you this question, that as a community health medicine specialist, you've done research, you've done studies, you teach that at the university. The first question is, at that level, I believe that we have learned a lot of lessons due to COVID-19 pandemic. Could you mention the top two, for example, important lessons that we have learned as a result of this pandemic when it comes to community medicine?
Well, I think the most important lesson we have learned is that we can use non-pharmacological interventions or public health measures like we took starting in China in late January and throughout the world through March to control a virus such as this. I think there was probably a lot of questions about what we would do in a situation such as this. And, you can go back and find people writing and commenting back in January when we were watching what was happening in China and saying things like that would never be done in a Western democracy. Right, and certainly we probably didn't implement the degree of controls like padlocking people's apartments and so on that China did. But we took on public health measures in March in this country that I think a lot of people would not have imagined we would have taken. So to me, that's a very important lesson, and data that's going to be generated out of this, and we have tremendous natural experiments. We have a big one happening south of the border that's going to generate data that will inform not only the future management of COVID-19, but future planning for other viruses of this nature. I think the other really important question relates to what we're just talking about is the world is a completely different place than it was 100 years ago or even 15 years ago, 17 years ago with SARS. Global mobility, so how fast things can move around. Globalization, in the lessons we've learned about PPE and ventilators and having facilities to do biologics like vaccines and manufacturing plants for antivirals. Like, Canada went along with the rest of the world and outsourced a lot of these critical supplies, right, as part of those global changes. The role of the internet and social media and rapid communications. And so, I think a lot of what we do in public health and in policy more generally, I think is based on principles for a world order that doesn't exist anymore. And even the issues around the role of the World Health Organization and the respect that different countries might have for it in coordinating an event like this. We didn't. One of the things I like to say is, none of the pandemic plans I was ever involved with anticipated that the failure in containment would happen in the United States. CDC at the helm, the world's best public health organization. So, what we're facing here in Canada is not the virus coming from China. We did have cases from China, but the vast majority of our community transmission in February, March came from New York, came from the EU, and came because of what was happening politically in different parts of the world and the kinds of responses that people had. And so, again, I think a really important lesson for not just for public health, but for public policy writ large is the plans, the approaches that we developed on a world order that got built after World War II globally, and the institutions we established have had lots of holes put into them. And the approach to globalization and outsourcing has resulted in a world that is not resilient. Not and our communities have a certain degree of fragility. And if we really want to be ready for future threats like this, we have to really think about some of those topics.
And are we ready for the next threat, in your opinion?
Well, I think our experience of the last 6 months suggests that we have work to do. But I think it is important for us to really bear in mind, and there's been comments from WHO and others, Canada has done well. If we consume our own media on a daily basis, we see all the flaws, and I think it's important to point out the flaws. We did not do well with long-term care and nursing homes. We did not do well with our agriculture workers and our meat packing plants. We did not do well with Indigenous communities. There's lots of places we did not do well. But if you look at how we did in January and February, we did what the plans called for. We were containing cases. And if we hadn't had those failures in containment in Europe and the United States, I think we would have been in a very different place today. If you look at our, the most recent seroprevalence studies coming out, our ratio of undetected to detected cases is about 4 to 1. Mm-hmm. US, other places, it's 10 or higher to 1. So despite all the concerns about testing capacities, and I know we had shortages and so on, it took time to ramp things up, we're nowhere near like a lot of other jurisdictions with that. And so it is important to bear in mind that I think, and a lot of that is the preparations we did after SARS and H1N1. And so we were better prepared, we were more vigilant than other countries. Certainly lots of room for improvement. But, I think if we really want to be resilient and not have to go through what we went through in March and April, we do need to think about why do we have only a couple of vaccine manufacturing facilities that are dedicated to influenza vaccine production, which is what we buy in Canada. We really have, other than our generic manufacturers, we don't have a lot of drug manufacturing capacity. We have very limited PPE manufacturing. We have very limited respirator manufacturing capacity. I think if we really want to say we're going to be ready for a big one in the future, we will need to think about those sorts of issues in our supply chains. Information systems. Where are we at with being able to share information on what's happening in emergency rooms, in ICUs, in real time, right across the country? A lot of work still to be done. Case counts, daily case counts. People are scraping websites to pull together national numbers. You have to go to news media to get good graphics. It's better now, but if we think back to where we were in April and May. So there's lots of areas for improvement for the country if we really want to say we're going to be ready for the next big one.
Vivek, there is a question by Janet Halliwell, CSPC Board Chair. I was interested in your comments that we need to give more attention to the public health questions that are not easily captured in our traditional approaches to research funding. Could you reflect on how we could do a better job of integrating such considerations in our funding systems going forward?
Yeah, so thanks for that question, Janet. So first of all, I think in the kinds of examples I gave, we have to think through when we want to use investigator-initiated competitive approaches and when we want to use more strategic funding mechanisms. And it was odd for me back in March and April as a VP research at a major research university, because everyone at CSPC knows that we always argue as much money as possible should go into investigator-initiated research driven through the granting councils, and that was our advocacy through the fundamental science review and what we always push for, right? But here I am saying there are times when we need to be prepared to do that more strategic sort of approach. So that would be the first thing, Janet, is being prepared to accept that there are going to be situations where we do need to fund research in a non-competitive way or through special competitions that don't go through the normal sorts of channels such as CIHR, SSHRC, or NSERC. The other thing, though, is on the public health question is making sure we have the research capacity in our public health organizations. And I think that for Ontario was one of the most important lessons from SARS, and I had the privilege of, based on those recommendations, of helping to build out Public Health Ontario, where we had an academic affiliation. We had scientists who were both doing applied public health work as well as doing research with academic colleagues. National Microbiology Lab has similar sorts of setup. BC Centre for Disease Control, which is part of both the Provincial Health Services Authority as well as the UBC, INSPQ in Quebec. We have a number of organizations, as well as the Public Health Agency of Canada, that straddle the worlds of public health and science. And this is, we've seen it in recent weeks, and I won't comment on how true the Globe and Mail reports about some of the shutdowns that Public Health Agency of Canada might have been or not. But what I think that really reflects is that when we have an event like this, we get the investments made, we get commitments, and then over time, people forget about it. And so, at the time of SARS, the public health labs in Ontario had been decimated. And in fact, in around 2001, the last scientists at the labs were laid off, and one of the communications people in the Minister's of Health office at the time said, why do we need a bunch of scientists sitting around waiting for an unknown virus, right? And 18 months later, we had SARS. And so Public Health Ontario, we built up the labs, we hired scientists, medical microbiologists, the people, we worked out a mechanism for them to do research. And then, again, in the years and as the time passed, they got more and more constrained, their funding got constrained. So I think, Janet, the second part of the question is to actually be able to do this applied sort of work that is relevant to public health, we need investments in science capacity in our public health organizations, which are largely inside of government or in government agencies. And I know this is something that Mona Niemer, in a chief science advisor role, has been doing a lot of work on, is we need to make sure that those scientists are adequately supported, they have the freedom to publish, there's appropriate guidance around how they do their work, so that we don't wind up with them being constrained in their ability to do the necessary science in a situation like this. And so a lot of that is not necessary. There is funding required, but it's also about making sure that the structures and mechanisms are in place for that type of science to be done.
Okay, thank you, Vivek. I just want to ask my colleagues at the CSPC office to launch the second question about our performance, how we have been doing with this session and the Q&A. I appreciate and your answers help us do better in future. And there is an interesting question by Molly Shoiket, and she is asking, how do we weigh the global pandemic versus every other health issue in terms of funding and treatment of patients?
Molly, thanks for that. That's a great and very important question. I've written several commentaries and op-eds on this topic, and I think it's really important that we take a population health approach, and we do need to be looking at what the consequences of our measures to control COVID are, both from a research perspective as well as from a health system and a population perspective. And so, we essentially shut down our health system to non-emergency procedures for close to 2 months, and some parts of the country even longer than that. We know from data emerging globally and in Canada that there have been consequences for people with heart disease, people with strokes, diabetes, cancer, for missed medical appointments, procedures. We see every day right now in the news the concerns about the consequences for our children from prolonged school closures. So we could go on. I think in our decision making and in our public policy discourse, and I think this is a really important issue for an organization like CSPC, we have to balance our discussions about COVID-19 with our discussions about these other issues. And the same applies, I would agree, on the science side. One of the things I'm constantly reminding people of is the reason we've been able to get investments of $2 billion into all this science, people doing antivirals work or vaccines. When I look at the researchers doing this, in February of this year, most of those people were not infectious disease researchers or virus researchers. They were working on cancer or diabetes or something else, and they repurposed. Well, the reason that they were able to do that is we had top researchers such as Molly in our country with well-equipped labs that could reorient. So if we don't continue to have our investments in fundamental science, we won't have and many of them had potential candidates that they could then evaluate and get for COVID-19 very quickly. So again, we need to make sure we stay balanced. Going back to my answer to Janet, we can't just go completely to mission-oriented, only strategic research. We have to maintain a balance of investigator-oriented research. We have to look at all our other global challenges. Climate change is not going to go away because of COVID-19. We might have a few less emissions for a few months. So our big global challenges still remain out there, and we can't lose sight of them.
Thank you, Vivek. And the last question is reserved for me. But before that, I want to bring everybody's attention to the deadline for the registration, early bird registration rate for CSPC 2020. Please do register for the conference in November. The early bird deadline ends in September, on September 27th, and there's a significantly reduced rate for the registration for this year's conference, which is online, as well as the deadline for CSPC Awards of Excellence, both for exceptional contribution to science policy and Youth Award, have been extended to, I believe, September 8th now. So the last question is, Vivek, are we going back to normal the way we used to live in, December 2019 or around that time? In terms of our social behavior, in terms of our daily work, what is, as an expert in community health medicine, what is your projection based on the things that you have seen and you see in the future?
So, I think Theresa Tam in her press conference last Friday rolled out scenarios that they're working towards. And first of all, in an absence of a vaccine, we could be looking at several years, as long as 2022, of what is characterized as the slow burn scenario, where we're going to continue to have cases, sporadic outbreaks. The worst case scenario is to try to make sure we avert a fall wave and we're able to manage it if we do have a fall wave like we did back in March. It may or may not be more challenging. The second waves are often larger, and the current timing will project it to happen at the same time as other respiratory infections. So the short answer is, in the absence of vaccine, we're not going back to anything like what we were at last year. I think we're going to have physical distancing, mass gathering limits, mask wearing mandates, lots of calls for hand hygiene, people who are able to do their work from home to continue to do their work from home in order to minimize the number of contacts in the community to a manageable level. That's going to be in place for some time to come. And a word about vaccines. I, as much as anyone else, have great hope for all the candidate vaccines, and there's some into trials, and we have one approved in China for the military, and we have one approved in Russia. But I think the reality is that it will take time to get an acceptable vaccine, or vaccines. It's more likely we'll need multiple vaccines for this. And to get through all the assessments and so on, to be able to address the concerns that people will have about vaccines being appropriately tested. So I think we're still a good year or 6 months to a year before we get close to having something like that. And then we have to bear in mind that we have to run a global immunization campaign. If we want to say things go back to the way they were, we will have to run a global immunization campaign. And just look at the history of global immunization campaigns and how many years it's taken for smallpox, polio. We're just getting there. It's a non-trivial task. And so I think we have to be realistic, and that's why Molly's question is really important, because how we're going to go about living with COVID-19 for that period of time can't just be about COVID-19.
Right.
It has to be about how we move forward as a society.
Excellent. Thank you very much, Dr. Vivek Goel, for this exceptional word of wisdom. And we are very pleased to have you here with us and look forward to have you in future. That brings us to the end of the interview. And our next session will be an interview with Anton Holland, President and CEO of NIVA, on science and risk communication during a public health crisis. This interview will be on September the 10th. At noon, so we will be on a break holiday for a couple of weeks until we'll get back with our virtual sessions on September 10. And once again, please do not forget to register for the CSPC 2020, the biggest science policy conference that we have had, and perhaps the one in Canada, with 80 panels, 300 plus speakers, and about 50 interviews on demand, and some other virtual functions and many other interesting aspects. Look forward to have your presence there. Thank you for your participation today. And I want to give the last chance and last word to Vivek for his final words.
No, I just say thank you for the opportunity to have this discussion, and thank you for everything you do. I know this is a passion project for you. But you've really done a lot to bring the science and policy community together in this country.
Thank you very much, Vivek, for your kind words, and have a wonderful afternoon, everyone. Look forward to hearing from you, and please send us your ideas at info@sciencepolicy.ca.
Thanks. Bye.
Bye.